I'm going to be recording our third part of our diabetes adventure. I hope you've enjoyed the lectures. Just want to start by saying I really enjoyed the weekend and all the simulation labs. It was good to get to see each one of you and spend some time getting to know you a little bit better. Alrighty, here we go. All right, diabetes are part 3 and final part for diabetes. When we think about complications, particularly with type 1, DKA, diabetic ketoacidosis, should come to your mind. That's the one of the main general complaints or complications that can occur. The two etiologies that can occur that cause DKA are decreased exogenous insulin availability, for example, poor compliance, in other words, they're not taking their insulin, or increased endogenous glucose, example, taking in a whole bunch of steroids. Okay. The patho of DKA. Hyperglycemia increases plasma osmolality and the blood becomes hyperosmolar. Okay, so it has a higher concentration. Extracellular fluid draws intracellular fluid out because things are going from a lesser concentration to a higher concentration. That leads to cellular dehydration and osmotic diuresis. As DKA progresses, glucose is in the bloodstream, not in the cells now. So our G's that we talked about earlier have to kick in. First, your short-term goals or your short-term needs, and then your long-term needs. This results in a further increase in glucose levels. Fatty free acids are converted to ketones, and ketones accumulate. Bicarbonate sodium are lost through diuresis, so the buffer is actually now gone as well. The respiratory rates alter to compensate for decreased pH and becomes what we call Kussmaul's respirations. And this is normal for someone who is having DKA or NDKA to have Kussmaul's respirations. Acetone, because the acetone, they have what we call the fruity breath. And serum potassium is a very important key thing. It may appear normal or elevated, but the cell, remember, is actually depleted. So remember what we said about the functions of insulin right off the bat. One of the functions that I said you're going to have to remember later on was the transport of potassium back into the cell. That's a major function of insulin. Something to keep in mind when we talk about starting an insulin drip here in just a little bit. Clinical manifestations of DKA would be mental changes, nausea and vomiting, abdominal pain, the Kussmaul's respirations, the fruity odor, hypothermia, hypovolemia, polyuria, glyceruria, and water loss between 4 and 12 liters. So that is a massive amount of water loss. Cellular dehydration is very common. So the serum is hypertonic and the urine is hypotonic. Lab findings, hyperglycemia. Okay, and it's a high reading, way over usually 350. Hyperkalemia. Remember, it's not actual. It's what we call transit hyperkalemia. Because what we have done is depleted the cells and it's all inside the extracellular fluid. But as soon as we start that potassium drip, what's going to happen to that potassium? It's going to be transported right back up into that cell. So when it's transported back up into the cell, we'll actually end up with hypokalemia. So for the first 4 hours, you probably will see them in a hyperkalemic state. But once the insulin kicks in, starts pulling it back into the tissues, for the next 4 to 24 hours, you better watch them for a hypokalemic state. That's why it's not unusual for them to start a bag of IV with potassium in it. And I know you think, my goodness, their potassium's high when they come in. Now we're putting potassium in their IV bag. But if they have an insulin drip, that insulin's going to transport that potassium back into the cell. So once it does that, it's going to drop what's in the extracellular, so you have to have something on board to replace that as well. Metabolic acidosis is common. We talked about that. You start breaking down fats and proteins, you start throwing off acids. Leukocytosis, white blood count may go up greater than 10,000. Dehydration, and that causes increased serum osmolality, increased hematocrit, increased BUN. Management of DKA, IV insulin. And usually it's a slow rate, about 5 units per hour to 10 units per hour with hourly blood sugars. Hyperkalemia is quickly reduced with fluid and insulin replacement. We talked about that earlier. Initial fluid is normal saline. We'll give 1 liter over 1 hour or less, so it's going to go in quickly to rehydrate those cells. Followed by half normal, about 1 liter every 2 hours with 20 to 40 of potassium, depending on the potassium level. When the blood sugar gets about 250 to 300, they're going to give D5W or D5NS or D5.5. Why would we add sugar? Well, that's necessary because we need to restore the muscle and liver stores as well, because remember, during the G's, they spit out all of their supply. So we've got to go back and put in, restore those stored cells in the muscle and liver in the form of glycogen. Management is also, the acidosis has to be taken care of, and that is reversed with insulin, because what's that going to happen? Well, once I give the insulin and I have insulin on board, I'm going to quit breaking down my fats and proteins, so therefore I'll quit throwing off the ketones and the amino acids. So once I quit breaking down those and I have the insulin, then I will not have the acidosis anymore. I's and O's, vital signs. They may be also getting central venous pressure checks. Note, hypokalemia is a major cause of death in DKA. The deficiency is in the intracellular, so don't be fooled. That's why we administer potassium early. So just a little mnemonic here, cartoonish thing to help you. We've got diabetic ketoacidosis, usually occurs over a 4 to 10 hour period. What causes it? Either a lack of history, lack of insulin, GI upset, could be an illness. What's it result in? Well, you get that fruity smell because of the acetones, the Kussmaul's respirations, thirsty because of the dehydration, tachycardia, hypotension, and acidosis, a high blood sugar, and this is greater than 240, and like I said, usually greater than 300, hyperkalemia, and polyuria. So what do they need? They need high E. So how do you fix ketoacidosis? I give them a high E. They need hydration, insulin, and electrolyte replacement in the form of potassium. Hydration, insulin, and electrolyte replacement, so the high E. Complications. Type 2 results in, instead of diabetic ketoacidosis, someone who has type 2 gets what's called HHNK, or now HHS, that hyperosmotic non-ketoic acidosis. The client produces, not acidosis or coma. The client produces enough insulin to prevent DKA, so they don't have DKA, because remember, that's what causes DKA in type 1, the lack of insulin, so they have to break down fats and proteins. Now with type 2, they've got enough insulin on board to prevent DKA, but not enough to prevent HHNK or HHS. They still have the hyperglycemia, the osmotic diuresis, and the dehydration, but they don't break down the fatty acids, so they have no ketones, therefore no acidosis. So that's the main difference in DKA and HHNK. With HHNK, you don't get the acidosis because you have insulin on board. Clinical manifestations: extremely high blood sugar levels, hyperosmolarity, and here you can see greater than 800 or plus, osmotic diuresis. So it takes a while to build up HHNK. Normal saline for the first 2 liters during the first hour of treatment, and then half normal. When blood sugar falls to 250 to 300, again, we're going to convert over. IV insulin for hyperglycemia. No acidosis reversals needed, so we give it at a lower rate, usually 2 to 5 units per hour. Potassium is not as much a concern because there's some insulin in the cell, because the insulin is on board. Complication of type 1 and type 2. Hypoglycemia is defined as blood sugar less than 70 milligrams per deciliter. Etiology, because what causes hypoglycemia? Either too much insulin, too little food, or excessive exercise. Some personal accounts I can tell you about. Again, my sister after pregnancy was on Diabinase. We know it has a long life, anywhere up to 72 hours. Her blood sugar, they did not check it. Went in, gave her meds. It was quite low, like 60, and she got to drink milkshakes for the next 3 days, as well as getting lots and lots of D10 pushed, or D50, I'm sorry, D50 pushed. So I'm telling you right now the seriousness of hypoglycemia. We talked about that. Remember, it damages brain cells if you let it get to that point. My grandmother went to a retired assisted living center to try it out for the weekend. She got there and she was a brittle diabetic. She had a hypoglycemic attack. The little assistant gave her went in and seen that she was hypoglycemic and gave her orange juice with sugar, even though she was in a semi-comatose state. Therefore, she aspirated. And unfortunately, she did not survive the incident. She ended up with pneumonia and some other things because of that. Have a nephew that drowned a few years back. He was out swimming in the Strawberry River, with several friends, and got out there, and he had not ate his snack before exercising and made it out to the rock, but when he turned around, did not ever come back. And they found his snack in the truck that he was supposed to have eaten. So I cannot stress to you the importance enough of hypoglycemia and the dangers that it can cause. So just keep that always in the back of your mind and know the signs and symptoms of hypoglycemia. Decreased glucose stimulates the central nervous system to release epi. So you're going to have cold sweats, trembling, what we call the shakes, nervousness, irritability, pallor, tachycardia, confusion, and fatigue. So if you got a diabetic, watch these signs and symptoms. Treatment. Ingest a simple fast-acting carb, orange juice, soft drink, hard candy. Most of you seen when we did our little experiment how much sugar content is in most of these things, so you know that it doesn't take much to get it back up. Once improved, then you want to eat a longer lasting carb, such as milk and graham crackers, which is a good one, or bread. If the client is not alert, administer glucagon, 1 milligram sub-Q or IM. This stimulates the liver to convert that glycogen to glucose and release it. In the hospital, of course, we give amps of D50. Now, one of the things you want to keep in your mind is glucagon injections may induce vomiting, so you want to position them on their side after giving. So you want to make sure you always position someone on their side after giving. Hypoglycemia has the little acronym then. Watch for tachycardia, irritability, restlessness, excessive hunger, cold sweats, diaphoresis, and depression. Okay, chronic complications of type 1 and type 2. You got your micro versus your macrovascular changes. And if you'll remember earlier, I told you that the key to preventing those is maintaining their blood sugar as normal, close to normal as possible. Someone asked me, well, what causes them to have the eye problems and to go blind while they were here over the weekend? Well, the thickening of the capillary basement membrane results in decreased tissue perfusion to that area. And what causes that? High blood sugar levels. So if you can alter and control those, it will slow that down. That slows down your retinopathy, neuropathy, nephropathy, as well as your blindness. Your macrovascular changes can also be alterable with controlled blood sugars. That would be like your coronary artery disease, your peripheral vascular disease, and your strokes. Okay. Other things is you may see they may suffer from erectile dysfunction, gastroparesis, neurogenic bladder syndrome, neuropathic arthropathy, which we'll discuss in a little bit, infection inside yeast infections, cystitis. All right, something we need to talk about is 2 conditions of fasting hyperglycemia that can result and the dangers of it. 2 conditions of fasting hyperglycemia and the dangers of it. One of them is called the Somogyi effect, and this is a rebound hyperglycemic situation. There's a good visual on page 1487 in your book. I'm going to turn over there as well myself. It talks about it, not actually a visual, but it talks about some of this. No, that's not the right page, sorry. Let me find the right page. Alright, let's see where it talks about this Somogyi effect. You just want to hear me turn my pages, so I know. Alright, can't seem to find it right this minute. But in your book, there is a picture that shows the difference between what I'm going to be talking here about as far as the Somogyi effect. That bugs me when I can't find something. Okay. It's actually on page 1434 in your book. Sorry about that. 1434. I just wrote down the wrong page number. Alright, and if you look on page 1344, you'll see what I'm fixing to be talking about here. The lack of available insulin versus the dawn phenomenon versus the Somogyi or rebound effect. What happens with the Somogyi effect is the hypoglycemia during the night with rebound hyperglycemia in the morning. This is more common in type 1 diabetics. Hypoglycemic episodes at night will cause the release of epinephrine, will cause the release of glucagon, and growth hormone and cortisol levels are also rising in the morning because of the circadian cycle. So if you think about it, we said those were counter-regulatory hormones. Your epinephrine, your glucagon, your growth hormone. So they increase glucose levels. Then you've got cortisol and your growth hormone also levels rising in the morning. And we also know that those increase glucose levels. So because of that, you're going to have clinical manifestations of nightmares and early morning headaches because they've had a hypoglycemic episode during the night. Management, what we're going to do is go in to see if they have this effect and check the blood sugar at 2 a.m. particularly. They also maybe do a 4 a.m. and a 7 a.m. Decrease insulin, what we're going to do to fix it is decrease their insulin dose or change the time of their injection. So, and even having them like eat a snack at bedtime helps. So there are things that we can do to fix this. So we can either decrease the insulin dose or change the time they're getting it or making sure they're eating snacks at bedtime. But let's think about this. What's the danger of this? Well, the healthcare provider may assess the situation as hyperglycemia and actually increase the insulin dose. So it's important that if you're getting extremely high levels in the morning, and this is a type 1 diabetic, that we do a 2 a.m. blood sugar to make sure they're not having this rebound hyperglycemia. Or otherwise, if you just increase the insulin dose, you're going to make this situation much, much worse. The dawn phenomenon, you have early morning rise in blood sugar with no hypoglycemia during the night. This is more common again in type 1. It is related to nocturnal elevations, again, of the growth hormone and cortisol levels especially. And it's also prevalent in adolescent and young adulthood because of the hormonal changes. Management, change the time and dose of insulin. So, for example, if they're on intermediate, they may take it at 10 p.m. so that it peaks when the growth hormone and the cortisol levels are being released and peaked as well. So if you look on page 1434, you'll see their lack of insulin and what it causes. It's the blue dots. And if you look at the dawn phenomenon, which is the red circles, you can see there the levels stay pretty stable during the up till midnight. And then even up to 3 a.m. it's staying stable. But about 3 a.m. till that morning time, about 9 or 8 a.m., it is really spiking up because that's when your cortisol levels and growth hormone levels are going up. You can see there the last one with the Somogyi effect, though. If you look after midnight, it's starting to go down. And between 2 and 3, you really have a sharp peak downwards where they're bottoming out. And then we jump way back up when the growth hormone and the cortisol levels are going up, so that we end up with a higher level in the morning, appearing to be hyperglycemic. So let's do a checkpoint. Joe Green, he's 18, he has type 1 diabetes. Yesterday, he was admitted to your unit with flu-like symptoms. He tells you that he hasn't taken his insulin for 3 days because he can't eat solid foods. Mr. Green's at risk for DKA as a result of what? If you picked A is polyuria, B is dehydration, C is lack of insulin, and D is decreased appetite. Well, this has been occurring. He hasn't taken his insulin for the last 3 days because he can't eat solid foods. And now he's telling you that he's developing DKA. Well, why do we think he's developing DKA? If you go back and look at the reasons why, then you should have picked C. When a patient has type 1 diabetes, he has an absolute lack of endogenous insulin. He has to take insulin. So without the exogenous replacement, he's at risk for developing diabetic ketoacidosis. When assessing Mr. Green, you notice that his respirations are deep and rapid, a sign that his lungs are attempting to A, increase the CO2 level, decrease the CO2 level, increase the bicarb level, or decrease the bicarb level. And you should have picked B, decrease the CO2 level. When a patient experiences diabetic ketoacidosis, ketones and acids are spilling into the bloodstream. The respiratory system is going to be the one that has to compensate, remember, and they're going to do that by trying to eliminate that excess acid. How are they going to do that? By increasing the respirations in depth and rapidness to decrease the carbon dioxide level. So remember, that's why Kussmaul's respirations are normal. Your assessment of Mr. Green's neurological system will probably reveal alert mental status, lethargy and disorientation, tremors, or seizures. If you picked B, lethargy and disorientation, you're correct. You're most likely to see neurological change such as lethargy and disorientation in a patient with hyperglycemia and diabetic ketoacidosis. Because if you'll remember, acidosis suppresses the central nervous system. That was one of the things we learned in ABGs. You'd expect Mr. Green's arterial blood gases to show A, a decreased pH and increased bicarb, B, an increased pH and a decreased bicarb, C, an increased pH and an increased bicarb, or D, a decreased pH and a decreased bicarb. And you should have picked D. In a patient with diabetic ketoacidosis, fat metabolism releases fatty acids and ketones in your blood, decreasing the pH and the CO2 and the bicarb levels. The kidneys excrete some of these excess ketones in the urine, and the respiratory system compensates by increasing respirations and decreasing CO2 levels. Administering insulin prevents a patient's body from using fat as a fuel source at this point. Martha Evans is admitted to your unit with type 2. During your assessment, she tells you that she drinks a lot of fluids and urinates frequently. Polyuria in clients with diabetes is primarily caused by A, hypertension, B, increased osmolarity of the blood, C, hyperkalemia, or D, altered fat metabolism. And you should have picked B, increased osmolarity of the blood. Polyuria commonly occurs in patients with diabetes as a result of increased osmolarity of the blood associated with hyperglycemia. That leads to osmotic diuresis. Which of the following statements is correct about type 2 diabetes? Less than 50% of diabetic clients have a type 2. Well, we said 90% had type 2. Its onset is abrupt, and clients often present with diabetic ketoacidosis. We said people with type 2 don't go into diabetic ketoacidosis. It's predominant type of diabetes in young adults. And if you remember in type 2, it's in the older population. It develops most commonly in midlife or later. And that is what is the one that should be the correct answer for type 2. Glucotrol, second generation sulfonylurea, is commonly used to treat type 2 diabetes because A, it stimulates the secretion of cortisol, B, it increases the serum glucagon levels, C, it increases insulin production and the number of insulin receptors on the cells, or D, delays absorption of glucose. And you should have picked C, increases insulin production and the number of insulin receptors on the cell. And that was in our lecture. That was just a review. You might want to go back and look at those if you missed them. So what's some other topics related to diabetes? Foot care. Foot injury is the most common complication of diabetes, leading to hospitalization and amputation. In fact, half of diabetics develop what we call hammer toe and claw toe deformities. And if you don't know what that is, you may want to look some of that up so that you can be able to visualize that and see it better. There is a visual of Criot's foot on page 1446 to give you an example of what can happen with their foot. Bunions are also common. Decreased blood flow slows healing. Neuropathy causes tingling, burning, and itching with complete or partial loss to sensitivity to touch and temperature. And that's why I had y'all do those microfilaments. That's why it's very important that diabetics check their feet regularly. As far as things to remember before teaching, the scope of low health literacy in the United States. 40 million Americans cannot read or write. So when you hand them those pamphlets and walk out of the room, a lot of times you've done a disservice to your patient. Goes back to our teaching, learning principles, assessing the level of knowledge, what type of learner they are, and including them actually in the teaching process. The U.S. average reading level is about 8th grade. Most pamphlets are written at 10th grade, so a lot of people can't even read the pamphlets and understand them. Watch labeling clients as non-compliant. And after y'all went through your exercise with me, you can understand why they have problems. Assess the level of knowledge. Can't say that enough. Patient teaching related to foot care. They need to check their feet daily. Washing their feet with mild soap and water, lukewarm water. Taking care of their toenails are very important, especially after bathing when they're soft. You want to teach them to cut straight across. Don't cut too close into the cuticles. If they have a corn or callus, don't dig the knife out of the kitchen sink and start cutting on them. Worst thing they can do. Also warn them about over-the-counter medications to remove corns and calluses. A lot of those products contain acid, and that can cause skin ulcerations and infections in diabetics. Best thing they need to do is see their doc. Protecting their feet is very important. Keeping their blood flowing well. Working with their healthcare team provider. No lotion between toes. You don't want anything that's going to cause friction. They need good shoes and shoes that fit. No nylon socks. Use cotton. Keep from slipping and sliding. All right, let's talk about diet and exercise. Well, with type 1, they may need it to increase calories to achieve body weight. They may need diet and insulin necessary for control. And they need equal distribution of carbs throughout the day. And y'all learned that by doing the dietary challenge last week again. Between meals and bedtime snacks are recommended. That's why we did snacks. And additional carbs required for physical activity. So if you've got a diabetic and they're going to be doing something physical, they need extra carbs or a snack before doing that. Type 2. Why is it important to teach about diet and exercise? Well, now we're doing it to decrease caloric intake. Low-fat diet. No snacks are recommended unless they're on insulin. Protein, and you need to know these. Proteins are recommended for a type 2 to be 10 to 20% of their daily calories. 89 to 90% is distributed between fats and carbs, with 50 to 60% going to your carbs and 30% going to your fats. Saturated fats should comprise no more than 10%, and cholesterol about 300 milligrams per day. Why less fats? Because the known increased risk of MI, strokes, and other blood vessel diseases. Simple versus complex sugars. Of course, complexes are better, so you want to make sure that you have complex sugars on board. Increasing their fiber to at least 25 grams per day, and that's a lot more than most people get in. And when we were doing that increased fiber diet, a lot of you realized that it takes a lot of fiber, usually anywhere 35 to 40 to actually be considered high fiber. So just asking them to increase their fiber to at least 25 grams a day is asking a lot. And you can get that through your beans, cereals, whole grains, fruits, and vegetables. Helpful hints: use non-stick cooking spray instead of butter, oils, and shortenings. Limit your butter, salad dressing, and gravies. Eat less fried and more baked, broiled, and grilled and steamed foods. Choose 1% or skim dairy products, but I do want to warn you about the skim dairy products. When we looked at the skim dairy products, they were a lot lower in fat, but they were high in carbs and high in sugar, so just note that. Eat red meats no more than 3 times a week. Season your foods with low-fat flavorings and spices, and use sugar and salt in moderation, mainly complex sugars. What about alcohol and diabetes? To indulge or not to indulge? Well, adults, if they are going to do it anyways, we tell them to limit it to 1 to 2 drinks per day. That would be for women, 1 drink, 2 for men. Don't ask me why we're discriminating there. A drink equals 5 ounces of wine, 1.5 ounces of hard liquor, or 12 ounces of beer is considered that. Now, to indulge or not to indulge, what we need to talk about here, if you think about it, a lot of people think, well, alcohol has these calories, so if they drink it, it's going to boost their blood sugar way up. Well, what happens is when blood sugar levels start to drop, if you think about it, it really has to do with your liver. Because what happens is your liver steps in, and it goes to work changing those stored carbs into glucose. Remember that. Well, then it sends out that glucose into your blood, which helps to avoid low blood sugar reactions. So when alcohol enters your system, everything changes, because alcohol is considered a toxin to the body. So when your body reacts to alcohol, it's going to react to it like a poison, and the liver wants to clear it from the blood quickly. So in fact, the liver won't put out glucose again until it takes care of the excess of alcohol. So if your blood sugar level is dropping during that time, it's trying to get rid of the alcohol instead of worrying about the low blood sugar levels. Therefore, it does not kick in and help. That's why drinking as little as 2 ounces of alcohol, about 2 drinks on an empty stomach, can lead to a very low blood sugar level. So just something to keep in the back of your mind. Diabetics, food products. Well, we know they're expensive. Teach them to read their labels. So here's going to be my challenge. I want you to pretend a diabetic just came over to visit you in your home, and they said, you know what, I'm just a little bit hungry. So I want you to go into your kitchen, and I want you to pull something out that you think would be adequate to feed a diabetic. Then I want you to turn it over and look at the nutritional facts. I want you to look at what constitutes a serving size, how many carbs were in it, how many fats were in it, and actually read if it really would have been the best choice to actually give the diabetic or not. If it says non-fat, it's full of sugar. If it says low sugar, it's full of fat. So you really have to teach them to read labels carefully. The use of sweeteners is acceptable. Again, research is out on the dangers of added sweeteners. Sugarless and sugar-free. There is a difference in sugarless and sugar-free. They need to learn to read the product. Again, read the labels. Check calorie content. Again, contains fats to make up for sugars. So you have to watch that. Exercise. Well, what's our goals? You need to know this. With type 1, increase sensitivity, because that may allow for us to lower the dose of insulin. So if we exercise a lot, that can increase some sensitivity and we may actually lower our level. With type 2, weight loss, because we want to increase the insulin binding to receptors and decrease resistance. So here's our goal. We want to exercise 60 to 80% of the maximal heart rate for patients' age. So how do we know that? We subtract their age from 220 and multiply by 60 and 80%. Thus, a client who is 20 years of age has a maximal heart rate of what to what? We would take 20 minus your 220, which would be 200, and multiply it by 60 to 80%. So you should get anywhere between 120 to 160 is what their heart rate needs to be up while they're exercising. I personally can do that walking up a flight of stairs. So when you exercise, you need to remember the mnemonic FIT, F-I-T. F stands for frequency. How often? 3 times per week. I stands for intensity, 60 to 80% of your maximal heart rate while you're exercising. T stands for aerobic, which is 20 to 30 minutes with 5 to 10 minute warm-up. Pediatric considerations. These are in your book, 992 to, excuse me, I don't know if that's the right page number. Yeah, 992 to 1106. Let me make sure I've got the right ones. Since I wrote down some wrong ones earlier, I'm paranoid. Yes, 992 to 1106. Or excuse me, till 1006. Incidence. In type 1 and 2, it's increasing in both children. 1 to 3 will develop diabetes in children. Is that not scary? And it's actually become the most common endocrine disorder in children now. Why? Most people think it's because, again, a lot of our diet, lack of exercise, food craze, the all-you-can-eats, the poor eating habits, all those things are leading to that. And you'll remember type 2 is hereditary, so if you've got parents who have type 2, that even makes you more prone. There's what's called a MODY type, or mature onset diabetes of the young, that we're seeing a lot as well. School nurses, coaches, teachers, they all need to be updated and informed on diabetes as well, particularly if they're involved in sports, because things like basketball, they're going to need extra snacks available, and prior to practicing, they're going to need to eat some carbs. General principles, you need to ask about weight loss, polyuria, may be mistaken for enuresis, no calorie restricted diets. They don't put them on calorie controls anymore. They watch their carbs. Sweets and juices can be worked in with children. Children less than 7 should have 3 meals and 3 snacks. Over 3, you can omit the mid-morning snacks, so 3 meals and 2 snacks. Hemoglobin A1C with children, this is the goals we want with children. It's a little bit different than adults, because you remember we wanted them below 7. With children 0 to 6, they want it between 7.5 and 8.5. Between 6 to 12, less than 8. Between 12 and 19, less than 7.5. And then older than 19, we want it less than 7, which is adult. What is their role? Well, we got to teach children that they're going to have to be part of the process, because they're going to have this for life. So as young as toddlers, we can start teaching them, you always have to wash your finger before we stick it, so you need to go wash your finger. Preschoolers, they can actually start helping with the blood collection process, depending upon the maturity level. But by school age, they really should be able to give their injection with some supervision, particularly our older school age. Now, you're younger, maybe not, based upon maturity again. Teaching children, they can only handle about 15 minutes at a time if you're a nurse having to teach a child. Adults have about a 45-minute window period. That's all you can teach them before they need a break. So which age group has the most difficulty adjusting? And the answer is dun, 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 adolescents. And that's because that's a time of stress anyways. They're trying to be perfect. They're trying to be like their peers. that everything someone says matters, and having diabetes means being different. Some will be more set up over a candy bar than an injection. Adolescent girls with diabetes tend to have frequent fluctuations of blood sugar levels, especially immediately before, during, and after their menses. Stress, if their parents divorce, leaving home, all those things also are going to increase their blood sugar levels as well. So just keep that in mind when you've got a child that's going through adolescence, that they will have fluctuations in blood sugars. Acanthosis nigricans. It's a condition marked by thickening or hyperpigmentation of the skin, commonly a sign of insulin resistance. And this is long before it progresses to diabetes, so it's a warning sign. Now, you need to make this part of your routine assessment with obese children by simply looking at the nape of their neck, their armpits, elbows, groin, or abdomen area. And I have put a website here that you can go to and look at pictures of that. Here's to give you an example. It is graded, grades 1 through 4. You can see there they will have a little dark line on their neck if they have acanthosis nigricans grade 1. Grade 2, 1 to 2 centimeters. Grade 3, 2 to 3. And grade 4, greater than 3. So this is, if like a grade 3 would be up to 2 to 3 centimeters. Once it goes over 3 centimeters, it's a grade 4. So I know that it looks like it's overlapping there, but if it says 3 centimeters, it's a grade 4. If it's 2 centimeters, it's moved to a grade 3. Okay. And this will, if you scrub and scrub and scrub and scrub, will wash off a little bit or lighten up, but it will come right back. I remember my sister growing up, my mom always swore that she wasn't washing her neck. She had a dirty, dirty neck. She would get so mad at her, and she'd take her in that bathroom and scrub and scrub and scrub, and it still wouldn't all come off. And come to find out, a few years later, she turned into a diabetic. So she really had this acanthosis nigricans. DKA in children is considered a medical emergency. Recurrent urinary tract and vaginal infections are often an early sign, particularly in your adolescence. In children, you will see at 8-hour fasting, they will have a blood sugar level greater than 126, a random greater than 200 any time of the day, and their last meal at the last meal time, or an oral glucose tolerance test greater than 200 on 2 occasions. So does insulin requirements change as a child grows? Why or why not? And the answer again was yes, and we talked about that because of fluctuations in their hormone levels as they're growing. Things to keep in mind. Most children are controlled with BID injections given before breakfast and in the evening meal. In children, we want to maintain blood sugar levels between 80 and 120 as our goal. The book actually suggests in order to gain the confidence of a child, the nurse demonstrates the technique by giving a skillful injection to the parent, who then gives one to the nurse. So what's your thoughts on that? Have to think about that one. With children, you want to use the pinch technique and inject at a 90-degree angle, unless they are extremely obese. But again, with type 1, which is the ones getting the injections, most of those are thin, so that's why they say use the pinch technique. Rotation of sites would be the same as the adult that we talked about. So here's an example question. Considering a child's developmental level and diabetic care is essential, the RN should include which information in teaching the parents of a recently diagnosed toddler with diabetes? Select all that apply. Allow the toddler to assist with injections. Remember, we said that was school age. Prepare meat, vegetables, and potatoes with every dinner. Not necessarily potatoes. Remember, go back to the plate scenario that we talked about and visualize your plate. Test the toddler's blood sugar glucose every time he goes outside to play. Well, what if he went outside to play 20 times in one day? I don't think you're going to check it 20 times. No. Allow the toddler to assist with cleaning off their fingers before the blood glucose monitoring. Yes, we talked about that. Allow the toddler to choose food selections from options offered. Yes, remember they are in the period where they want some autonomy and want to be involved in making choices. So you should have picked D and E. What about sick day rules? Well, sick day rules occur when a patient is sick that has diabetes. And one of the things that you want to make sure that you're doing, and these are listed on page 1456 in your book, is doing frequent blood sugar checks, particularly every 1 to 4 hours. Checking for ketones in the urine, taking insulin or hypoglycemic agents regardless if they're sick, monitoring I&O, temperature, mental statuses, maintaining fluid intake if they can't hold fluids, and on medications, notify the healthcare professionals. Test for ketones, okay? If it's slight ketones, then usually we're going to increase their fluids and some calories. If it's elevated ketones, then they need to see their physician. It is recommended that the urine be tested for ketones every 3 hours during an illness or whenever the blood sugar level is over 240. If vomiting, diarrhea, or fever persists, you want to take liquids every 1.5 to 1 hour to prevent dehydration. Remember, 5 to 15 meals to provide some type of calories. Current research that's going on, we talked earlier about inhaled insulin being a supplement to meal times to decrease the postprandial blood sugars. Intranasal, they're looking at that, again, to supplement at meal times. Non-invasive blood sugar monitoring, they're looking at MiniMed glucose sensors, and we have those now that go with the actual insulin pumps. The watch, putting a watch on and wearing it, all kinds of little gadgets they're trying to develop. Let's see, glucose measurements via saliva and tears is one thing they're looking at. They're looking at a finger probe system similar to a pulse ox. Insulin patch, transdermal delivery systems, one of the things that's in current research. So you can see they are trying all kinds of things to help diabetics. There is something called the Edmonton Project Protocol, and this is where they've actually done a transplant of islet cells. You had to have certain criteria to enroll, and about 1 million islet cells had to be transplanted to produce enough insulin to replace the needs for injections. Sources for organ donators, they've used pigs, bioengineering. Immunosuppression is required if you have, of course, transplantation of any type. What they will do is go in, and transplants are often performed by a radiologist who uses x-rays and ultrasound to guide placement of a catheter, which is a small plastic tube, of course, through the upper abdomen into the portal vein of the liver. The islets are then transfused slowly through the catheter into the liver. The patient receives a local anesthetic and a sedative, and in some cases, the surgeon may perform the transplant through a small incision using general anesthesia. The islet cells begin to release insulin soon after transplantation. However, full islet function and new blood vessel growth associated with the islets do take time. The doctor will order many tests to check blood sugar levels after the transplant, and insulin is usually given until the cells are fully functional. So you can Google this and see where they're at with this at this time. There's also some alternative therapies that they're looking at that you can look at, and some genetic research. Just a case study to consider and do. If you want to do this case study, you're welcome to look at that case study, and then I also on the next page have some questions related to that case study. So if you want to do this, it's optional. You do not have to, but I'll be willing, if you want to send me an email, to give you feedback on that. All right, I hope you enjoyed the lecture on diabetes. You learned a thing or two. I'm always open to suggestions for improvement. Feel free to let me know if you have any questions, any concerns. Call me or email me if needed, and best of luck on the exam. One of the last things I want to talk to you about is end-of-life issues. What's your thoughts about keeping strict diabetic control at the end of life? So in other words, you've got a diabetic. They've said they're not going to make it, and they're asking for a supersized Milky Way. Is it going to hurt to give them a supersized Milky Way at this point? Probably not. So one of the things that research has found is that, management of diabetes at the end of life should consider their needs and their wants at the end of time. So one of the last things that I want to leave you with to remember is to wish more. When you think about a diabetic, wish more. W stands for weight control. I stands for insulin management. S stands for don't forget to manage sick day rules. H stands for know your signs and symptoms of hypo and hyperglycemic in the management. M stands for maintenance of foot care. O stands for no smoking. R stands for revving up your engine to exercise. And I stands for eye care and always evaluate. As I've told you, don't forget, laughter's the best medicine. So if you haven't laughed lately, you need to. Thank you.